I think one of the biggest misconceptions is with fatigue is that there's nothing you can do about it, just accept it. And I totally disagree with that. And I think it's an undervalued side effect. As we said, it's not necessarily life-threatening, but it's definitely something that can interfere with patients' day-to-day quality of life. So we really need to address it. So it is a big deal. So we need to assess, communicate, and plan for it.
You're listening to the Oncology Nursing Podcast, where ONS Voices talk cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Welcome to the Oncology Nursing Podcast. Hello, and welcome to the Oncology Nursing Podcast. I'm your host, Jamie Weimer, Oncology Clinical Specialist at ONS, and today we are joined again by ONS member Paula Anastasia, Clinical Nurse Specialist for UCLA Medical Center in Los Angeles, California, to discuss how to assess and manage fatigue resulting from PARP inhibitor maintenance therapy. Paula facilitated an ONS focus group on the topic on July 29, 2022, during which the group specifically identified fatigue as one of the most common and challenging side effects to manage during extended maintenance therapy. This podcast episode is supported by a sponsorship from AstraZeneca. ONS is solely responsible for the criteria, objectives, content, quality, and scientific integrity of its programs and publications. Thanks for joining me again today, Paula.
Thank you for having me, Jamie.
I think fatigue is a pretty compelling topic in cancer care because it seems to weave its way through virtually all treatment modalities. Many of our patients, I think, will come into their treatment journey early on with those preconceived expectations of experiencing maybe the dreaded nausea and vomiting or hair loss that we know is associated with some of the original cytotoxic therapies, maybe not as universal across all therapy types now. So patients might be relieved to hear, oh, well, thank goodness I'm not going to have to worry about those symptoms. But the challenges in experiencing treatment-associated fatigue can sometimes, I think, catch them by surprise, because sometimes it's the most challenging symptom to overcome, I think primarily because maybe there's no easy fix. And this is what we heard from our focus group regarding patients who are taking PARP inhibitors for their 2 or 3 year maintenance therapy course as part of their treatment for ovarian cancer. So to start from the beginning, can you help briefly just define fatigue and maybe explain how it's different than the normal tiredness you or I might experience, and what causes that fatigue in cancer treatment?
Thank you for that nice summary and for the lead-in question. It's so interesting. When I was thinking about this topic, just kind of what you said, fatigue is not necessarily life-threatening. So I think, unfortunately, it's underplayed at how disruptive it can be in somebody's quality of life and day-to-day life. So I think it's a really important topic. Now, if we get really technical and look at the NCCN guidelines on cancer-related fatigue, they define it as distressing, persistent, subjective sense of physical, emotional, or cognitive tiredness or exhaustion related to cancer or cancer treatments that's not proportional to recent activity. So most of us have fatigue in our life, right? Whether we work inside or outside the home, taking care of your family, whatever that looks like, kids, parents, friends. Stress is present in all our lives, whether it's due to finances, emotional illness, people have anxiety and depression, and this can add to the fatigue. So for those without cancer or other illnesses, we often have a resolution, a relief of this fatigue. Oh, I'm just going to go to bed early and get a couple hours of sleep tonight, or I'm going to have a cup of coffee. But people with cancer, it's not an easy fix. So I think it's important when we talk about partnering with our patients that we ask our patients how much they sleep at night and if they feel rested upon waking in the morning. I think that's very telling. I ask them also if they need to take a nap or rest during the day and how many times a week, and if that is also helpful. Most of us can get sleep or take a rest during the day and be re-energized, but people with cancer, they describe it as much more long-lasting. It's not easily resolved with a quick fix. And they describe it as just being exhausted or spent or they hit the wall. And this can be daily, not for those of us that just had a tough week meeting deadlines or jet lag or something like that. For people with cancer, it's ongoing. And we know that cancer in and of itself is the primary cause, but it's not one dimensional. So there's other things that can add to that, such as chemotherapy, which can have secondary consequences such as low blood counts and anemia. We know targeted therapy can add to fatigue. Immunotherapy, which can have other side effects such as hypothyroidism and other endocrinopathies. And then radiation therapy is a very different type of fatigue that patients will describe different than chemotherapy. So it's really important to have these conversations with your patients, have them tell you about it. Tell me about your fatigue. Tell me on a scale of 0 to 10, because it's very subjective. And we know that there's other things that contribute to it, like unmanaged pain and emotional distress and interrupted sleep. In my female population, obviously, that have surgically induced menopause, that interferes with sleep. So again, it's so many things can add to it.
It sounds like basically everything we do to our patients can cause fatigue. And that's a great point, because if it was one single thing on its own, maybe it would be more manageable. But we know it's never just the one thing. It's whether it's multimodality treatment, where they're getting 2 or 3 different things, coupled that with the emotional distress of just going through a cancer diagnosis, as you mentioned, like it compounds itself. So even the best of us are going to struggle with this fatigue in this setting. So is there anything specific that makes fatigue caused by PARP inhibitor maintenance therapy especially challenging to manage?
So our patients with a PARP inhibitor have completed upfront IV therapy, and usually it's going to be carboplatin and paclitaxel every 3 weeks. And it's kind of predictable in the sense that the first week patients are going to have side effects and they're going to have fatigue. And then they start to feel better in the second, leading up to the 3rd week, just in time to have their second IV therapy. But the challenge with a PARP inhibitor is because it is daily, and whether they're taking it once a day or twice a day, it's more every single day, as opposed to, oh, well, next week, after the 2nd week, you're going to have a lift of that fatigue and you're going to feel a little bit better. I think that that's a challenge, especially when patients are just finishing therapy. And again, I've not had carbo and paclitaxel, but it's not as disruptive side effect wise as some of the other chemotherapies. And most patients say, yeah, it was tough, but there are worse things. And they start to feel better. And now we say, hey, we want to give you this PARP inhibitor. And one of the common side effects is fatigue. And they're like, what? I'm just starting to feel good. And now you're going to throw me into fatigue. So that can be a challenge as well. And I think it's really important when we educate our patients, letting them know that this is a common side effect. But the research tells us, and also patient experience, that fatigue does plateau after about 4 to 8 weeks. It's not 0, but it gets much more manageable for our patients. So I think priming our patients with what to expect can be very helpful.
You made 2 really great points there. One, the daily therapies that don't have that cyclical approach. We don't have that promise of it'll get better in just a week or 2, or this is just your nadir. This is when you're going to feel your worst. It's when it hits you, it might hit you and stay that way, because it is a daily therapy without necessarily breaks built into that schedule. I think you also touched on a really important thing at the end there about setting our patients up with the right expectations. And I think because it might be perceived, well, it's not chemotherapy, it's just a pill I take, I'm going to feel just fine. And so if they go into that therapy with that mindset of this is going to be no big deal, they might, again, feel that fatigue even more disruptive because they went into it thinking that it was going to be fine. So setting them up with the right information so that they're prepared in case they do have fatigue that is not manageable or really disruptive to their daily life, that at least will give them the right mindset going in about what to expect. So those are some really important points you made there. So what can we do about it? What interventions are most effective for managing fatigue?
Well, Jamie, you know this as well as I do. And I chuckle when I tell my patients that I'm going to tell you how to combat fatigue, but now I'm going to lose all my credibility because you've just told me that you have fatigue, but I'm going to tell you one of the ways to mitigate it is to be active. And they're like, what? Paula, I just told you I was tired. I can't exercise. So again, I want them to have some type of physical activity. And again, it doesn't have to be hours and it doesn't have to be, I'm exaggerating with marathons, but just 10-minute walk in the morning and then maybe a 10-minute walk in the afternoon, things like that, we try to, if possible, refer patients to a physical therapy type setting initially, and that will help give them tools on how to be active in safe activities and also gets them motivated. So that's really helpful for patients and energy conservation and to prioritize activities. So again, patients are busy, whether they work inside the home, outside the home, taking care of family, or just taking care of themselves, meal planning, cleaning, those types of things. But perhaps that afternoon or that evening, they have an event where they're going to be going out to lunch or dinner or attending a party or a theater or whatever it is. Then they want to prioritize. So they may need to do less in the morning or rest an hour before that activity. So prioritizing what they need to do. It's important to delegate. That's not easy to do. But when I educate caregivers, oftentimes they'll say, oh, just call me if you need anything. Well, that puts ownership then on the patient. So I try to tell patients up front, it's okay to delegate. Patients, they have friends that say, oh, is there anything I can do? Well, I'm going to tell you what you can have them do. They can run errands for you. They can go to the grocery store for you. They can drop off meals. People want to feel needed and wanted. So I think that's a good way also to help them prioritize their energy. It's also important that, things we take for granted, like self-hydration, many of us don't hydrate enough, but people with cancer, they definitely don't. And dehydration can cause more fatigue. We know poor nutrition. There's vitamin deficiencies like low magnesium or vitamin B deficiencies. So making sure that patients are properly nourished. And if they need to, we can refer them to a dietitian or a nutritionist, things like that. And also just mindfulness of the types of foods to eat. We know that heavy carb loading is going to make somebody more tired and less productive over time. So those types of things. Mindful meditation, I'm not big on that, but you know what? That's really, really important. Just the deep breathing exercises, getting the oxygen in, that can really help energize and center people and also help them for nighttime sleeping. So there's lots of things that we can do. I think it's important, I should have said at the beginning, is to assess the cause of the fatigue. So ruling out anemia, hypothyroidism, vitamin deficiencies, things like that. So if that is ruled out and we know it's what we're doing to our poor patient with the interventions, they've had surgery, they've had chemotherapy, and now we're going to put them on a PARP inhibitor. So all these lifestyle changes, but activity is really, really important.
I had to chuckle when you started out with the physical activity talk, because I can still see that look those patients will give you. They're like, you got to be kidding me. Like, this is the answer. But you're right. And truthfully, that's a whole different episode about physical activity for patients who have cancer and how that can help them in so many ways. But it is challenging. It's challenging to, especially in the throes of feeling fatigued, to say, well, I know you feel like this, but here's the answer. Be more active. And that's a challenge. And so even back to what we talked about already is setting that expectation, letting them know ahead of time, regular activity. And I always try to avoid saying exercise because people associate that in different ways, mostly negative, or I guess I'll speak for myself. But, I think that feels almost impossible to say, I'm going to go exercise. But saying physical activity, regular activity, move your body, stay active, using some of that terminology instead. And as you mentioned, giving them sort of a prescription for activity. If you just say, go home and exercise, they might not know where to even start or what to do with that. So even giving simple instructions, walk to the mailbox and back 10 times, or if they've got a safe neighborhood and they're steady on their feet, walk around the block once. So giving them just some of those incremental goals to set for themselves and work towards so that they don't feel like it's up to them to figure out what to do. And maybe it's not even that. Maybe it's get up and pick up a little clutter around the house or fold some laundry. I mean, it can be as simple as that for people who are truly that fatigued, but anything that gets them up out of the chair or up out of bed with some purpose on a regular daily basis, I think is at least a great starting point. But you're right. That's a hard message to sell when they're just got done telling you how hard it is and how bad they feel, but it truly can't help. And we know that the research tells us that.
And I love how you're giving them structure. And I think that's really important. I do ask patients, I said, now, do you watch TV in the evening or during the day? I know a lot of people are streaming now, but if you're watching TV and there's a commercial on, that's your cue to stand up and just march in place. How long is a commercial? And use water bottles so that you're getting some bone density work there as well. So again, like you said, just some structure, walk to the mailbox, and it doesn't have to be a lot. So those were good ideas from you as well. Thank you.
As you had already mentioned, sometimes it's referral to physical therapy for them to help create that structure or give those tools, as you'd mentioned. I know there are some community-based programs for exercise programs like through the YMCA, specifically designed for patients who have cancer. And so some patients would love that. They love that structure and that routine. And so that might be a great solution as well. So some other things to keep in mind. Let's say that while we've given all these recommendations, patients are still continuing to be fatigued. What are some of those potential complications that can result from fatigue that can't be managed or doesn't resolve?
I don't think of fatigue as having a complication, but of course it does, because we know that, looking at what's manifesting is, and going back again for something simple as hydration, patients that are just poor self-hydrators. And there are situations where we may need to bring them in for IV hydration. The nutritional aspect again. And sadly, there are people that have food insecurities. It's like, oh yeah, eat your fruits and vegetables. It's like, well, I don't have money to buy that kind of food. Assessing, working with the social worker, make sure that our patients do have food accessible, and also they have the information that they're having the right types of foods. And I think once again, looking at vitamin deficiencies are really important. I'm thinking things like low magnesium can cause a lot of leg cramps and difficulty walking. And that's something that we can simply assess with a blood test. And that's why it's really important before you start a PARP inhibitor, we are doing baseline labs from the CBC and the chemistries to rule out or see if there are any baseline things that we need to correct, such as anemia or electrolyte imbalances. And we know also the psychosocial aspect of it. I think since COVID-19, there's a lot more awareness of how much people have anxiety and depression with or without COVID. But I think we're more in tune to that and how stressful life is. And that's not even having cancer and all of the challenges with that. So I think that plays into it. Depression, anxiety can contribute to fatigue. That can interfere with work and home balance. And think about the caregivers. And it's like, oh, I'm so tired of her being tired, and just relationship issues. So I think that it's something really important if we don't get it under control. And that goes back to communicating with our patient and asking the right questions and addressing them. Again, it can be very, very disruptive, but it's not something that you can necessarily see. It's very subjective.
I think it goes back to how you started our conversation today. It's not life-threatening on its face, but as you've just described, it can sort of sneak its way into these really important parts of life, of relationships and psychosocial aspects and what makes life joyful. And if it really is starting to disrupt those things, that's a huge impact. And ultimately, if it's that profound, potentially patients may be non-adherent, right? They might stop taking their meds because they feel so terrible. So you're right. It's not something that causes these direct, challenging, life-threatening complications, but it's that sort of downstream ripple effect that really, as you said, we have to be mindful and intentional of asking the right questions to get to the heart of how that patient is feeling with regard to their fatigue. Speaking of that, how can nurses, or what are some of the ways nurses can ask those questions to assess patients for, are they having fatigue, or what is their fatigue experience like for them?
So I think it's really important when we ask questions, especially if it's subjective, that we ask open-ended questions. I really try to emphasize this, and I fall into it. It's like, oh, do you have fatigue? Yes. Well, that's not really helpful, right? So old school, now I went to nursing school probably, 39 years ago. And so we were taught the assessment was using that acronym, the old CART, onset, duration, characteristics, associated factors. So I try to keep that in my head. So when I ask the patients, tell me about your fatigue, when did it start? What's the duration? How long does it last? Is it all the time, or does it come and go? Is it predictable? What are the characteristics, such as, can you complete tasks, or it's just an effort to get out of bed? But once I get it moving, I'm better, those types of things. Any associated factors? Is there shortness of breath with exertion or dizziness, which would be more telling for me to say, hey, there might be some anemia going on here. What are some of the relieving factors? Do you get a quick fix with a 20-minute nap? Or does activity, does a yoga class help you? Those types of things. So what have you done? And I always ask them, what were you able to do last week or last month, depending on when I see them, that you were not able to do this week or this month? So sometimes they're very specific, or sometimes they'll just say they're now prioritizing. So they've given that up. But that's really helpful information. So once again, I always say, tell me about your fatigue and describe it. What does it feel like? And I think it's helpful to use the 0 to 10 scale, 0 having no fatigue. And then, as I mentioned, when we start a PARP inhibitor, we always want to obtain a baseline CBC and comprehensive chemistry panel to rule out other issues that need to be addressed. And then, depending on your practice setting, they may draw the blood weekly, or they may do it monthly and then quarterly. And I'm going to leave that to the package insert, because I know people have different ways of doing things, and you may be using different PARP inhibitors in your practice.
I really like how you described not only the open-ended questions, but asking patients to give context to how the fatigue is changing their ability to do things that are important to them. And I think those questions tie in directly with how we help patients identify their goals of treatment and their priorities when it comes to treatment, and ultimately helps us decide, is this treatment the right one for the patient? If they're saying, my most important thing is to be able to go on a daily walk with my wife or my husband, and I can't do that now because of this treatment, that becomes that conversation of, well, if that's your most important thing, and this is now making that not possible, what do we need to do to change it so that our treatment is matching what your goals of care are as the patient? So I think that's a very important question, especially with something like fatigue that is so subjective and so personal. Those are some great tips on questions and how to ask them beyond just the, are you tired? Yes, of course I'm tired. Okay, so we've talked about what is fatigue, how can we assess for it, or even some recommendations that we can give patients to hopefully help mitigate it, ease the severity of it. But what are some common barriers or challenges that you see patients facing in managing the fatigue?
It's interesting because and I learned this from the focus group too, because every practice is different. Every patient is different. So patients are motivated to go on a PARP inhibitor because the goal is to prevent or delay a recurrence. We saw a patient 2 days ago that came to us for a second opinion, and she was the classic completed frontline therapy, had very low side effect profile with her carboplatin and paclitaxel. She also had a germline pathogenic variant, and her oncologist wanted to, rightfully so, recommend that she start on a PARP inhibitor. So she presented to us for a second opinion. She's like, I feel so good, and they told me that I was going to have fatigue and these other side effects, so I don't want to do that. Why do I want to take something that's going to make me feel badly or feel worse than I do now? So that's important too. And I think that's really important when we have that open communication with our patients. Number one, why are we recommending a PARP inhibitor? To prevent or delay a recurrence. Number one, that's key. That's huge. And also to let them know what the side effects are, but please communicate with us. We are here to help you. We can lessen or mitigate these by you letting us know. So I think that's really important. And also, not to downplay it, we do know that the fatigue side effect will plateau after 4 to 8 weeks. That does not mean they won't have any fatigue, but it's a lot more manageable. So I think that in itself is a challenge when we're starting off. It's like, well, I don't want to feel worse by starting this new medicine. So I think just keeping that open communication, and also letting the patient know that one dose does not fit all. And I know, Jamie, you've heard me say this before, but when we start PARP inhibitors, there is the recommended FDA dose, but that's why we're monitoring patients on a weekly or a monthly basis to see how they're doing. We may need to do a dose hold if they're having a grade 2 or higher fatigue. We may need to do a dose reduction because not one size fits all. So again, letting the patients know that we're not just going to give them medicine and say, hey, you're on your own. We will be monitoring so they can live their best life.
I think that is some great tips to keep in mind as we are working with our patients and kind of helping them through the transition from their frontline treatment into this maintenance phase, of just things to keep in mind, ways to communicate with them, which really is kind of my next question. So along those same lines, and maybe we've touched on this, let's go a little deeper if we can. What is the nurse's role in helping patients manage their fatigue during that sometimes 2 or 3 year long stretch of the PARP inhibitor maintenance therapy? What can nurses do, or how should they see themselves, their role in managing that side effect?
I think nurses are really key in managing oral therapies. I think it is challenging because you're not seeing this patient every 3-week basis with an IV therapy. You may or may not be doing telemedicine. You may be having your patient come in every 3 months, depending on your practice setting and the MD discretion. I'm not saying that's right or wrong, but that is reality. You're not always seeing your patient, but it is important. You have to be communicating, whether you and the patient are calling or my charting every 1 to 2 weeks, or if you're fortunate enough to have an oral therapy support panel in your office where they're following up on a monthly basis. But the only way, I always tell this to my patients, is like, I'm here to help you. But the only way I'm going to know if something's not working or if you're feeling ill or not well is you need to tell me. And so once again, we have to keep that line of communication open and let them know that we are here to help them, and they can call us and who to call and those types of things. But I think it's also important to just prepare them ahead of time what to expect. I did a support group one time, and I may have told you this, and everybody listening right now is like, Paula, we just don't care. But we were talking about fatigue, and somebody like called me out, and they said, why doesn't anybody tell us that when we're done with therapy that we can have fatigue up to 2 years? I needed to know. That was important information. And I do know that sometimes we just neglected to say it, or you don't want to lead the witness. But we want this information, because if I have this information, I'm empowered and I can be proactive, and I know what's normal or expected and what's not normal. So once again, I know I just keep saying communication, but it is so important that we're a team. And I think it's the nurses that are having the relationship with the patient in managing these side effects. And we do it well, but we have to do it together.
I agree completely. We are trusted by our patients. They sometimes, I think, see us more when it comes to frequent treatment visits and things. And so they become very attached and very trusting of their nurses and the relationship of their healthcare providers. And so I think you're absolutely right that we should be excited that we serve that role for our patients. And I also think, not to get philosophical, but I think that educating patients and encouraging them to stay physically active is completely under the umbrella of wellness and health promotion. And that is nurses' domain of practice. That is not something that always needs a prescription from a licensed, credentialed provider with privileges. That's a nursing task. We can say, here's what you can do to help yourself, to make yourself feel better. And so giving those recommendations for physical activity and how to help manage that fatigue, that's our stuff there. We can't give that up, because that's one of the many things that we can do on our own independently, because that's within our scope.
Exactly. And that's all part of survivorship.
Absolutely.
That's what we're doing. Our patients are surviving.
And we're helping.
Because we're helping them stay healthy.
That's right. Absolutely. Well, what a great topic. I think will always be a challenge. Fatigue is just one of those nebulous things that maybe we'll never fix, but I hope that we continue to learn tips and tricks and interventions that we can recommend to our patients, in addition to physical activity, that will help them feel a little bit better and really retain that quality of life for many patients, because they'll be on therapies maybe for long-term maintenance, maybe years, maybe lifetime. And so if this is something that's going to continue to find its way into their life that they'll have to deal with, I hope that the science continues to evolve so that we can best support those patients for the duration of that treatment. So to wrap up, we'll kind of summarize some of the things we've talked about using a few little quick questions here. Starting off, what are some common misconceptions about fatigue and PARP inhibitor therapy?
I think one of the biggest misconceptions with fatigue is that there's nothing you can do about it, just accept it. And I totally disagree with that. And I think it's an undervalued side effect. As we said, it's not necessarily life-threatening, but it's definitely something that can interfere with patients' day-to-day quality of life. So we really need to address it. So it is a big deal. So we need to assess, communicate, and plan for it. And again, partnering with our patients, letting them know that we can help improve it, lessen it, by them telling us how awful it is. It's also important, though, that even though, like I said, it plateaus and patients do learn to live with it, and most patients will have pretty good quality of life and be able to complete their ADLs and their goals and the fun things that they want to do in their life. But it's interesting, after they finish their 2 to 3 year course, and of course, I'm saying that they did not progress. They completed their therapy as we expect them to, 2 to 3 years, that once they go off their treatment, they're like, oh my goodness, I feel so much better. I didn't know how bad my fatigue was until I stopped my medicine. So once again, I don't downplay it, but it is something that we can manage.
What is something about fatigue that's not often discussed, but you wish people knew more about?
Well, I think it's important to know that number one, we can help our patients through it. And there are many non-pharmacological interventions. And like you said, activity, from yoga to walking to just being active. And I think that's really important, that self-care that many of us don't do. But I think that the non-pharmacological interventions, even like massage therapy, that can help relax people so that they can get a better night's sleep, things like that. But there's also, in some situations, there may be pharmacological interventions like stimulants. And I'm not recommending this for everybody. This is a select few. But I think that's very important to know that there are other things to do in individual settings. So I don't think that patients should just have to accept their fatigue. I think it's something that we have to assess. And again, with a multidisciplinary team, from support groups to nutritionists to physical therapy.
Yeah, I think that's a great recommendation. And just acknowledging that if we don't ask the question and we don't assess appropriately, we might never know how the patient's feeling, how bad it's gotten, or maybe we'll miss the opportunity to intervene when it's more manageable. So just bringing it up as something that it's a reality, it happens. And so we want to hear about it from you, the patient, telling us how you're feeling. It's not a complaint. It's just what we need to know. That's great information.
It's reporting.
Right. So what additional training or education should oncology nurses pursue to address fatigue that is caused by PARP inhibitor therapy or other cancer treatments?
Obviously, they need to be a member of the Oncology Nursing Society because we give so much excellent information. But just what you said about communication, I think documentation is something that we're lacking a little bit on as well. So consistency is very important. I'm a fan of the common terminology criteria for adverse events, the CTCAE. And I always say there's an app for that. And so I think that's really helpful when you're documenting, a patient says that they have fatigue. What does that mean? Able to do their ADL. So like a grade 1 is relieved by rest. Grade 2, fatigue is not relieved by rest, limiting instrumental ADLs. I don't want them to get past a grade 2. Grade 3 is fatigue not relieved by rest and limiting self-care and ADLs. And of course, anything further, they have fallen off the cliff. But so most of my patients are going to have a grade 1. But I think it's really important if patients are not doing well and they advance this to a grade 2, a little bit, what does that mean? So if you're not specifically documenting what the patient's telling you, what they're able to and not do, at least put a grade in there so there's consistency to see if they're getting worse or having improvement.
I think that's so important, especially when we're assessing and trying to document side effects that aren't discrete numbers. How do we know if it's better or worse if we don't use as precise of tools that we have available? And sometimes they're not there, but as you mentioned, CTCAE is one methodology of assessing and grading toxicities where at least there's a common definition so that we know maybe I don't have this patient every week, but when they came back this time, last week it was a 1 and now suddenly it's a 2. So something has changed. And we might not pick up on that if we're not documenting or we're not documenting in a way that helps us to trend those changes over time. So that's a huge thing. I definitely agree with you on that.
And since I just plugged that for people that aren't familiar with that, like I said, there's an app for that. When you put in the fatigue or anemia, they'll grade it for you. So it's not like you have to be an expert on what the grade is. They will tell you what the grade is. So that's easy.
Sure. And there might be other scales too. I mean, there might be other scales to use, but look at your institutions. Usually it's an electronic medical record these days, but it's important to understand are there different ways to document certain side effects, or how does your institution have that set up to grade those or to document an assessment on those? And is there improvements that could be made? Are they just asking for mild, moderate, severe? Could it be changed to a numerical scale or a CTCA format? So maybe some things to explore at your own institution if you feel like improvements could be made on how that documentation takes place. So again, another topic. We're coming up with all great topics here. What are some additional resources for patients and providers who want to learn more?
I'm a big fan of the NCCN guidelines, and they have the NCCN guidelines for patients. So I do recommend patients going there. And especially my new nurses, my new grads, or those that don't necessarily have experience in oncology, I do recommend looking at the guidelines for specific supportive care or disease specific. I think they're very helpful. I think cancer.net has a lot of great support for patients, and they're user friendly. ASCO has tear-off sheets for cancer-related fatigue. And again, recommendations that is going to be reinforced by everything we've suggested today. And then there's, for ovarian cancer and cancer-specific advocacy groups, there's lots of information out there. And supportive services, many people in their work setting, they have supportive services or social workers, that sort of thing that can provide things. And then back to the physical therapy, we can refer patients, sometimes insurance will cover for that, encourage the exercise activities, online yoga classes. It's becoming more prevalent. I even know our institution and some of the patient advocacy support groups out in our community are offering online yoga classes. So that's huge. And again, just for self-care. So that's been something I think we're going to see more of.
That's great. Those are all great resources. I would also add a plug-in. At ons.org, we have a page about a campaign that was called Get Up, Get Moving. And it's a whole structured sort of educational initiative to help nurses understand, how can I teach my patients about physical activity? What can I recommend? How can I recommend this to patients? And even provides videos with demos on simple exercises and things. So there's lots of information out there. Clearly, if you want to learn more, or if you want to start, maybe be your own site's champion for increasing the physical activity of your patients to help them combat their fatigue, there's lots of great information out there. So thank you again, Paula, for joining. Do you have any final comments to share today?
Well, thank you, Jamie. I just love these segments with you. And again, I know this segued off of our focus group, so I really want to thank those nurses that participated. But I really am thankful for ONS for continuing to provide the education to the oncology providers to help improve patient outcomes. And I love now that you guys are providing all this accessible format. So from online, I still like my hard copy journals so I can hold and read on the airplane. These podcasts are great. And now that we have in-person and virtual conferences, so there's just, the resources are just expanding, and we have no excuse not to take advantage of these. So I'm really grateful, and I'm always inspired and energized with the nurse and patient advocacy program. So thank you, ONS, and of course, thank you, Jamie.
Well, thank you so much, Paula. Again, appreciate your time today, and thanks for sharing all this wonderful insight for us.
Thank you.
Thank you for listening to the Oncology Nursing Podcast. Tell us about your favorite part in this episode by leaving a review wherever you download your podcast. For more resources and information about oncology nursing, visit us at ons.org or voice.ons.org. The ideas and opinions shared in this episode represent those of the guest and not necessarily ONS.